Hel- Hello, can you hear me? Can you hear me?
Yes, sir. Yes, sir. We can. Yes, sir.
So, are you getting something on the screen?
So we can see the axial cut of the CT.
Okay, so this patient is for sinus surgery who has been operated before, and see the kind of problem he's having and the reason behind that. So, first of all, role of CT scan. CT scan is not to determine the disease but to look at the anatomy and in revision situation what went wrong. So what can be done best? So the best is to get a CT scan done in DICOM format and see on the lower left corner it is 1 mm sections. With this software you can reconstruct into all planes. See this. Once you reconstruct, let me show you, you can further reduce the slices. For example, now look at this, I further thinned out the slices. Now it is 0.3 mm.
Yes, sir.
Every movement, see, I move, it moves by 0.3 mm. So you don't actually miss any vital structure. Okay?
Yes, sir.
Number one. Number two, see this massive whiteout in spite of surgery done, what this disease is. So let me tell you, this sinus disease is a medical disease. You have to understand. There are variety of endotypes of this disease. Every endotype has a different underlying pathophysiology for which a different treatment is required. All sinus disease patients cannot be treated on the same line. It is like a syndrome with a lot of things positively and negatively affecting the outcome. It is like a immune complex disease of the paranasal sinus mucosa. So anything which positively impacts the immunity will have a positive impact on the outcome. Anything which negatively impacts the immunity will have negative impact in spite of multiple surgeries done. And once in this case polyps, it looks like eosinophilic disease which requires steroid and steroid. Like any other eosinophilic disease in the body. So like such patient, if you give oral steroids, it works on the cascade of entire development of polyposis. If you give oral steroid, they will respond well. But the question is how long you can continue. They have their own adverse effects. So the strategy now has changed, completely changed. In spite of a good sinus surgery done, the disease comes back. So you have to change the strategy of introducing topical steroids inside, by means of which you have to make the sinus cavities in such a way the patient himself can push the steroid deeply into the sinus mucosa where it is actually required, yet without the need of oral steroids, yet without the systemic dissemination, systemic absorption, and patient can continue for long or even for life. So accordingly the counseling should be done, otherwise it breaks the doctor-patient relationship. Many a time, even the patient Google and come back. Doctor, we have come to know that this disease is going to come back even if I get operated. Yes, 100%. So you have to counsel them that we'll get certain tests done to know the particular endotype, the kind of disease or anything which is affecting. And if it is eosinophilic, we'll give. The role of surgery is to remove this disease load. Whatever eosinophilic disease, whatever secretion, whatever fungus, whatever, we'll remove this load and give access to the topical. And our entire, this is a medical disease, the medical treatment starts after surgery. So your actual treatment starts after surgery and everything again comes back in your hand that you need to push the steroid topically for long. If you counsel that patient that way, the onus lies on the patient. No patient will understand the role of surgery is to give access to the topicals. Like patient who was cardiac stenting done, whose stent placed in the coronaries, will never forget to take anticoagulants. No one in the world will forget to take. Because they have been counseled that you stop anticoagulants, your stent will get blocked. Accordingly, you have to counsel them. The role of surgery is not to get rid of everything, but is a way out to get rid of your problems by means of giving access to the topical. And then once comes to the patient to give topical irrigations according to the need, according to the eosinophilia, according to the based of various investigation and endotypes. So, I am not going in the details because that science of CRS is quite big. Now see in this patient, in spite of the surgery, there is complete opacification. Can you see?
Yes, sir.
It looks like frontals have not been touched before.
Yes, sir.
There is intersinus septal cell. See this? And deficient intersinus septum, the entire frontal is a single cavity. See this? It is only anteriorly there is a partial septum. See, if I am going from anterior to posterior, this is partial septum. When you go behind, it disappears. Can you see? And see, there is lots of, this convexities, scallopings. And see, everywhere this mucosal disease is. The treatment, you have to ensure that your irrigation reaches everywhere. The role of surgery is to give good access. If the surgeon doesn't widen the ostia properly, doesn't give access properly, anything coming in the way means septum terminate, you have to treat. If the floor of the frontal coming in the way, beak, you have to drill it. Ultimately, the goal is to give access to the topical steroids. And then when patient delivers the topical, it goes everywhere, it becomes symptom free, problem free. So, this CT scan has a big role. See this, the frontal floor is completely intact. It looks like the frontal sinus was not touched earlier. Now, let me reconstruct to see the frontal. The frontals are best seen on sagittal plane. Look at the sagittal plane. The challenge in frontal sinus.
Yeah. Yes.
You are coming with endoscope from here, and frontal sinus is situated absolutely opposite to your plane. Clearly and up. And see, while you look with your endoscope from here, what comes in the way? This is the beak. This is the beak. That is the culprit. It doesn't allow you to visualize inside. It doesn't allow you to do instrumentation inside. So, why I am showing you, I will show you a perfect solution to the frontal problem for future. See this beak is the key. Frontal, identifying and dealing with the frontal sinus is complicated only and only by this beak. And beak is fortunately a landmark which you can easily identify. This is the thickest bone in this region.
Yes, sir.
With endoscope with 70 degree, you follow the beak where the beak ends in the frontal sinus. As simple as that. See this? Where the beak ends is the frontal. You don't need any other landmark for frontal sinus. Believe me, after seeing this, you will realize frontal is the easiest sinus to open and go inside. Now to further give it access, if this beak is too big, the opening is too narrow to deliver the topicals, don't think twice before to drill away this beak. Okay? The moment you drill away, it will be a highway to the frontal sinus. So, my focus will be on the beak. Focus will be on the frontal in this case. See this. Even there is osteitis in this region of the frontal outflow, which has narrowed this so much. His frontals have never been adequately treated. That's why his symptoms are not leaving him. So we have to do something concrete now so this patient doesn't come back. Look at the frontal on both sides. This is left side, this is right side. And the problem is the beak. See this?
Yes, sir.
Number one. Number two, going behind. I am not waste. Ready hai kya case? Chaudhary? Ready hai? Now, going behind. What you need to see is the ethmoids. See the cribriform plate. Ethmoids are like a common cavity with complete opacification. Full of mucosa, full of polyps. Mucosa, polyps, secretion, everything looks opacity in the CT scan. You can't discriminate. Now going behind, see the maxillary everywhere. The nasal septum, see behind in the post-ethmoids. And in the See now the kind of bony work done by the previous surgeon is commendable. Can you see?
Yes, sir.
But the problem is the post-operatively the patient was not followed up. Probably steroid irrigation was not advised or patient didn't follow and he has come back with this much of mucosal disease. So my point was I was explaining to deal with the sinus disease in a different way. Never ever tell your patient that we will operate, you will be all right. This will be the biggest joke, will push you in trouble someday. This is not a surgical disease. Surgery is the best avenue to make the medical treatment effective. So counseling to the patient should be accordingly done. Don't look at the moment surgeon looks at the polyp, he thinks of operating. Give adequate time for the workup to know the disease, to know the eosinophilia, know the aspirin sensitivity, know the immune aspect behind it. Any immune disorder, if you ignore, the disease is going to come back. Asthma, aspirin sensitivity, all these are factors which complicate, and your allergy, you have to assess thoroughly. If patient is allergic, you have to treat accordingly, which can further otherwise lead to eosinophilia and problem. So give time to adequate workup to counsel the patient that what kind of disease you are having, and then counsel, see, look, your is a medical disease purely steroid dependent. We cannot give you steroid for long, but we have to do something that you get steroid to the sinuses without systemic dissemination, and for which we need to open up your sinuses to make sure the steroid reaches. So the goal of surgery to give access to the topical, and your overall treatment, the core treatment will start after surgery. Don't think that we operate, you become all right. Your treatment will start after the surgery, which is the core treatment, that is medical, that is steroid. And you need to be under follow-up, close follow-up for long, in case anywhere the disease is, worsening, the eosinophilia happening, the polyps coming, you can accordingly treat medically by increasing, decreasing the, the concentration as well as frequency of the topical steroids and frequent, endoscopic debridement, whatever. Once you have done a full house FESS, the control is in your hands, that you don't need, the patient doesn't need any bony work. You further don't need a formal sinus surgery. What all is a calculated medical treatment, that too topical. Any questions before we move on?
Sir, I think we can start the surgery, sir.
Okay.
After this FESS surgery, we will have 15 minutes small inauguration ceremony, and after that there is one parathyroid. After that dinner and karaoke night. So please, this program is still there.
Yes, sir.
This patient comes to you for the first time after period surgery, total treating medically before you embark for surgery, or go on STD?
That's what I said. First, I will assess why it is coming back, how it was treated previously by the previous surgeon, how the post-op medical treatment was done. We'll get the CT scan done to see how adequate work is done. And then, see, once this kind of a problem, see, he has a complete whiteout with the frontal sinus untouched. So his previous work is not adequately done. So first we have to finish off with our whatever remaining surgical part to give access. See, if you don't operate this patient, how will the topical steroid penetrate into the frontal sinus? Our entire purpose is defeated unless you give a full access. Again, the same thing comes, the role of surgery is to give access to the topical. If your frontal is completely closed, how will the steroid reach inside? Whatsoever you give, it is going to be utter failure. Now, every endotype has a different impact. Suppose I am treating the aspirin sensitive disease. We have more than now 400 patients of aspirin exaggerated disease. All patients with polyposis with asthma has to be all those patients have to be worked up for aspirin sensitivity. If ignored, that leads to the highest level of inflammation in a paranasal sinus disease, CRS, highest level. Give highest level of eosinophilial leukotrienes which give maximum inflammation. If ignored, you operate 100 times, it is going to come back. So, in case you have identified as a AERD case, you have to explain your patient, your surgery will be more extensive. I will primarily do a draft to push more and more steroid because it is more and more highest inflammatory level, number one. We'll give widest enterostomies to push more and more topicals. We'll explain him that this is the role of surgery is to combat the eosinophilia by topical steroids. That's it. The disease process is not stopping unless we revert with aspirin desensitization. So the core part of the treatment is desensitization. That should be planned because that requires a long-term aspirin therapy. So that we do after surgery, after a couple of weeks of surgery when the healing takes place. So accordingly your patient is counseled. If not counseled, if not worked up for aspirin sensitivity, whatever your surgery you do is going to be a futile exercise. However number of times you operate, if you don't address the underlying pathophysiology, it is utter wastage whatever you do. That's why give some time for the workup before you take the patient on table. See now what? Yes, please.
Sir, how do you differentiate in a unilateral pansinusitis by CT scan to inverted papilloma neoplasm?
Yes. So you have to be very sharp at a CT scan and suspicious number one. Any patient, elderly patient particularly with a unilateral disease, not simple, watery polyps, something fishy, must get a good CT scan done. First of all, the plan is to get a non-contrast CT scan done, number one. When you assume a sinus disease, it is always a non-contrast. Now on non-contrast, you can easily miss, but if you are sharp, suspicious, you can notice the bony irregularity behind, abnormal, bony osteitis, excess bone, bony erosion, ballooning of the disease coming out of the sinus, which is unusual and unilateral, should be followed with the MRI. Otherwise, if you are not suspicious, you take the patient on the table for polyposis and you get intraoperative surprise of a tumor behind. So, you have to be very good at the radiology and your clinical suspicion on a unilateral, not completely watery polyp in an elderly patient. That is the first way of picking up. And then MRI is the game changing. This is left side, this is right side. Okay, I will show on one side so that we can save time for the other case. So now, first of all, look at what the previous surgeon has done. This is the middle turbinate. And there are polyps medial to the middle turbinate. See this?
Yes, sir.
This is olfactory region. Once you have polyps medial to the middle turbinate, one thing should click to your mind. Number one, such patient present with olfactory symptom. Number one, olfactory loss. Number two, in such patient, the middle turbinate is floppy. See this?
Yes, sir.
Once you have a polyps coming from medial side, it makes the middle turbinate floppy, and if you don't treat it, the middle turbinate, untreated turbinate itself can become the big cause of failure. पहले ही रखना चाहिए था। नहीं बोल तैयार हूँ बोले 1 घंटे से, लगाया कुछ नहीं, लगाने इसको हट यार, हवा में रहता है।
Sir,
Yes, please.
in this kind of patient, how many days you give free of
बहुत ऊंचा लगा रखा है। ऊंचा। How many days you give pre-op?
You give steroids, systemic steroids in this type of patient.
For the patient preparation?
Yes, patient preparation.
So, see, the role of steroid, number one, is why we are giving. Try to understand. This is inflammatory disease of the mucosa. An inflamed mucosa bleeds a lot. In endoscopic surgery, too much of bleeding compromises with your visualization. And in endoscopic surgery, if your visualization is not good, you are likely to give complication. So to maintain good visualization, to reduce overall bleeding, one of the strategies to reduce the inflammation, and the best and the most potent agent to reduce the inflammation is steroid. So whenever you finally plan the surgery, if possible, give couple of days to reduce the inflammation by means of giving steroid. Depending upon the so many factors, sometime, 5 to 7 days is adequate time.
So we have to do CT scan
Sir,
after 5
can you
to 7
reduce the
days.
pulse around 60? Pardon?
We have to give steroids, then we have to do CT scan in such.
No. See, CT scan is required only once for the anatomical detail. That's it. CT scan is not for diagnosis, not to be repeated again and again unnecessarily. Now, debrider. Now look at our turbinate is floppy, our middle meters is full of disease. See? So, first of all, I will take away these polyps to get more landmarks. You see, this is a surgery of landmarks. Margin of is very less. So everything has to be done under vision.
But you would send some tissue for the biopsy?
Yes, always. The most representative tissue is the polyp.
Sir.
To know the mucosal eosinophilia, and that's a good strategy to counsel your patient as well. And even you should know that how aggressive the eosinophilia is. If too much of eosinophilia, you can counsel your patient that you may require this steroid even for the life, for long term, because you have too much of aggressive disease. See the middle meatus? Polyp, full polyps. Turbinate is floppy. So we'll do a partial trimming of the turbinate. Whenever there are polyps medial to it, you need to give a good access to the steroids, to the olfactory region. And you really need to trim the polyp which comes in the turbinate which comes in the way. Now see, this uncinate is still there. Can you see?
Yes, sir.
The previous surgeon has not even done an adequate uncinectomy. See this? Even the uncinate process is not adequately removed. See, if whenever you operate, if your surgical work is not adequate, you are unlikely to get the result. See this? Once you operate, you have to give a good access. See what I am doing? Partial trimming. This is floppy. And see what I am giving now? Access of steroid to the olfactory region. This is the olfactory region.
Yes, sir.
I am not going to be aggressive to this olfactory region, mucosal polyposis, edema, whatever. Because once the steroid reaches there, this is going to revert, even the olfaction can come back. But if you are aggressive and giving too much of fibrosis there, you are ruining the prospects of olfactory recovery. So never ever be aggressive towards the olfactory region. Rather, be aggressive towards allowing the steroid to reach there by means of giving access. See the access to the olfactory now. But I have not, first of all, I have not pulled the turbinate at all. It is attached to the cribiform above. Number one. Number two, I have not completely removed it. See this? I have kept it as a landmark above. This is important for the skull base. See this?
Yes, sir.
But it is trimmed enough to prevent obstruction coming as an obstruction in my olfactory, in my irrigation. See this now?
Yes, sir.
This will never ever come back in my, see the polyps medial to it. This will not come in my way of irrigation. Can you see the olfactory?
Yes, sir. Can see.
Mucosa above. So, be gentle to it. Be gentle to the olfactory mucosa. No, pregnant. Now see my excess. Now, number one, I have just removed the polyps, trimmed the turbinate to improve my excess. We'll start our surgery with a proper uncinectomy now. A proper uncinectomy was not done earlier and is the biggest cause of problem now. These are my adrenaline shock marrow cells. We always request our anesthesiologist to reduce the cardiac output by means of reducing the heart rate towards around 60. See, in this surgery, the major source of bleeding is capillaries, which is best reduced by reducing the cardiac output. By topical capillary vasospasm by means of topical decongestant. See what I am doing. Same marrow cell pieces, soaking in saline adrenaline and reusing. Now, so use them in between to improve your visualization. See this?
Yes, sir.
Chota ada. Visualization is the key. The single most important determinant of complication is too much of bleeding. It doesn't allow you to identify the landmarks and then keep operating. Single most important factor. So give adequate time. See now the field. Yeah, wash क्या करना है यार? Invite करना पड़ता है तेरे को. डालना. Yeah. Chalo. Now give me the reverse biting. Now see where the maxillary sinus is. The ideal location is, this is your inferior turbinate. On the upper surface of the inferior turbinate, if you go laterally and down, this is your maxillary sinus. See this?
Yes, sir.
See this? Full of disease. And this is your remnant uncinate. This is something the previous surgeon has adequately not treated, I would say. See the kind. Now, once you remove the upper part of the uncinate, the first important landmark I look for, see this?
Yes, sir.
That is lamina papracia. Your lateral limit of the entire paranasal sinus corridor comes in your way. Visualize. See this lamina? All the way, immediately the moment you remove the upper part of the uncinate, you come closest to the lamina. Sometimes this too much of inflammation, eosinophilia, affects the underlying bone and present as osteitis. Osteitis is a bad bone which is full of depot of cytokines, inflammatory cytokines, and that bad bone is something which doesn't allow the antibiotics to penetrate, and you have to radically remove the osteitic bone. See my maxillary sinus from inside, the kind of disease there. दिखते हुए को don't be aggressive on the mucosa. Even this cobblestone appearing mucosa is likely to revert once the ventilation drainage is established and the topical steroids start going inside. See this? I am never going to be aggressive on the mucosa. Paranasal mucosa is the key. Sinus mucosa is the key. This is a FESS surgery, functional endoscopic sinus surgery. And function is served by the mucosa. If you radically remove the mucosa, that is not FESS, that is mess. Say this. Preserve the mucosa. You have to be gentle on mucosa. You need to know when you are supposed to be aggressive, when you are not. Here, looking at the aggressiveness of the disease, you have to take your surgical call, how widen your ostium should be. There is no hard and fast definition. If you don't have an aggressive mucosal disease, you can avoid wide meatotomies. Divider. Hope picture is good there?
Yes, sir. Yes, sir. It is very nice.
Yeah, feel free to interrupt me anytime if you have any doubts or any suggestion, any questions, anything. Please.
Sir, you use the steroid eroting stent, sir? Like you use
Never.
for 2-3 weeks.
Too fancy and too poor mode. Too fancy and too poor mode of steroid distribution. That is basically zone eluting stents, which keeps on eluting for 90 days now, and it costs thousands of dollars. That too static. The irrigation is dynamically reaching everywhere where you open. Nothing can match that. See, in a revision situation, you can't take a chance of a second revision. At least your surgical part should be adequately done. See my middle meatal enterostomy now? It should be adequate to penetrate the steroid inside adequately. See this?
Yes, sir.
Give me the through cut. Here. I should give a thorough access for the steroid to reach thoroughly. In any given situation, there should not be any surgical fault in allowing the mucosa to reach adequately. The goal of surgery is to give a good access. See the maxillary middle meatal enterostomy now. Now imagine, this is with 0 degree. If you train your patient to push steroid, and how easily it is going to go inside. Can you imagine? And imagine the situation before. So surgery, once done, should be done adequately to serve its purpose of topical delivery. Half-hearted surgery, inadequate surgery is of no use. See now, all middle meatal, the maxillary sinus mucosa is good, healthy now. Little edematous because of the lack of ventilation drainage, but now see the mucosa. We have protected the mucosa to function it, to allow it to recover, not remove the mucosa. Never ever. Now, coming above, I told you the way I am going to show you. I would love to know from you that a frontal sinus is the easiest sinus to deal with if dealt with properly. See now what I am doing, because God has given us a great landmark. I am removing this beak adequately. See this beak? Oh, sorry, this axilla. See the axilla region? Adequately open up the axilla. See, this is the mistake people do. With 0 degree, I am more and more opening the axilla high up. See this?
Yes, sir.
This is the key to reach the frontal. Adequately open up the axilla. Adequate means fully open up. Define your lateral limit, that is the, see this, lamina?
Yes, sir.
And medial approximate limit is your turbinate. See this?
Yes.
We can't go medial to the turbinate to breathe the skull base. And see what we have reached. Can you see the thick bone here?
Yes, sir.
This much. See with the 0 degree where I have reached. This much excess of the axilla should be done. The moment you see this, I will change my scope. Give me a pack for a while. Simplest way of treating the frontal sinus, dealing with frontal sinus.
Yeah, we following the beat.
Just, I have shown you on CT scan. Follow the beak, what is there behind? Frontal. It cannot change. It is God's given anatomy. Whatsoever the cellularity in the frontal recess is, this anatomy will never change. Whatsoever the number of revision surgeries to remove the landmarks, unless the draft is done, this is never changed. What an amazing landmark for the frontal, which I am going to show you. 70 है ना? नहीं अभी तो 0 ही है. I am waiting for the 70 now. See, after every step, decongest the mucosa for your better visualization. Okay?
Yes, sir.
This is not the wastage of time. This is saving the time. Now changing to 70 degree. 70 degree, you have seen the angle of frontal sinus on CT scan. How anteriorly and superiorly placed. क्या है ये? अबे ये तो लेरिंगोस्कोप है यार. This is laryngoscope, not sinoscope. Laryngoscope है. हाँ उल्टा है. Anyway, this is laryngoscope, boss.
Lens should face upward.
Now see what we have got. Mandal. Can you see the beak?
Yes, sir.
The thickest bone in this region. See this? Now, my concern in the frontal sinus surgeries are multi-pronged. I have a fear of, while dealing with the frontal sinus, I have a fear of orbital injury. I have a fear of skull base injury. I have a fear of arterial injury. So many fears, because frontal is situated in such a region that in close proximity are several tigers. How can you avoid? 70 degrees is the key. दे दे यार, इसको 1 किलोमीटर दूर रखा है. $70 degree is the key. पतला दे. Because now I have my all, see with 70 degree. Under vision, I have my lamina in view. If I keep an eye on the lamina while dissecting there, not crossing it laterally, my orbit remains intact. If I keep my turbinate in view and don't breach it medially, my by and large skull base is preserved out. Okay?
Yes, sir.
And if you work in this direction, like later, in this direction anteriorly, you are automatically away from the skull base behind. Got my point?
Yes, sir.
Now, wash. Now, why I am giving time to show you, so that you never forget. Only thing I am focusing is the beak. Can you see?
Yes, sir. Yes.
This beak is here, forming the frontal sinus floor. Beak, 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 beak here. Now, give me 120. Now I will follow this beak behind, staying between the medial and lateral limit. Both limits are in my view. See this?
Yes, sir.
The turbinate and the lamina. And if I stay in between these two limits, I will go nowhere except the frontal. See, in front of everybody, under vision, see my beak?
Yes, sir.
I am following the beak, following the beak. Follow this beak, follow this beak. See beak, where the beak ends is the, this is my frontal sinus. Yes, please.
What is your indication of external approach in which
In a,
what is your indication for external frontal sinus approach?
very rare in situations when the frontal sinus is very narrow or you have some pathology which is not being accessible. Can you see the frontal now?
Yes, sir. Yes.
How long did it take to reach the frontal? Few seconds. So confidently. Why? If I can do, anybody can do it. As simple as that. See this. What again, coming back to the landmarks. Follow the middle turbinate was a axilla here. Axilla. Anybody can see the axilla easily?
Yes.
Open up the axilla. Oh, yeah. Open up the axilla completely. Once you open up, you see the beak. Once you see the beak, follow the beak, you are in frontal. There,
Only possible because you read the CT or the imaging very correctly. So it is always worthwhile to spend time in reading your CT.
100%. No doubt about it, CT scan is a must. See now, the frontal. See this?
Yes, sir.
How easily I could reach in the frontal. Now I can say, if anybody looks at the axilla, follow the beak, can reach in the frontal easiest. Easiest sinus to open, I would say. Use 70 degree. Keep eyes on the landmark, Upanch. Now, the challenge is, see this is the posterior table and see the beak is so overhanging. Can you see? This beak is so overhanging, this will not allow my solution to go freely. Now what I am doing, this is my special articulated punch from Karl stores. And see, I am removing the beak to make the solution reaching more easily. See now? For whatever the overhanging beak, you can remove. Now suppose, still you are not getting the adequate access. This beak is the culprit, I told you. Beak is the culprit which is coming in the way. Drill away this beak.
Yeah.
This will be like opening the book. That is draft. Draft has devised variety of procedures. The end of the surgery, our goal is to give good access to the topical. You open a narrow frontal for the sake of frontal sinus surgery, which is not adequate enough to deliver the topical steroid. That is no fun. Patient.
Hello. Satish boss.
Yes, please, Devang.
So basically, frontal sinus has to be opened from landmark to landmark, right? And
Obviously.
So a lot of people say it should be 6 millimeter. A lot of people say
Bullshit. It depends upon the given anatomy of the patient. You can't dictate in millimeters. Frontal sinus could be very narrow, could be very big. You can open it adequately. Now, see this overhanging beak I have done. See now, you can push your, topicals more effectively. If still you are not happy, yes, see this. In minutes time, idea is my patient should be able to deliver steroid effectively.
before
I am not doing a classical draft. Just showing you, in case required, you can do a minimal drilling.
But does this drilling required in this given case for the sake of
Yeah, yes. It is required a little bit because my frontal axis is still narrow. This is a revision case. We can't take a chance. This ostium should not get blocked and there is no harm in doing it. Why to take chance for this poor fellow for the third surgery? See now?
I think the bone punch is a better instrument at this place.
Yes. If the too thick is a bone, you can use a drill.
Right.
So I am not removing the entire floor. I am just removing the overhanging beak. Saaf karna.
Boss, which drill have you used? Which drill bit?
Favorite stylus from Medtronic.
Tapering.
Yes.
Angulation is it?
This is a transnasal 15-degree naturally curved. See now the frontal from inside.
Yes, sir.
Suppose, imagine, had I not opened like this, now see the highway, I would not be so confident in pushing the topical so effectively. Now, this additional 2 minutes of extra punch and drill has made his life, amazing. That is what you need to do in frontal. You have to do
Dr. Satish,
adequate work. Yes, sir.
Dr. Prakash Mulkani,
Yes, sir.
is it adequate or still if you are not satisfied, you can take out that body overhang, which is visible, yeah.
Yeah, I can remove, but see, in this patient there is no mucosal excessive disease inside.
Okay.
Suppose, had there been a pathology inside, like tumor or something, I would not think twice and do a complete draft.
Yeah.
I would remove the floor completely. But here, see the mucosa is so good.
It's quite healthy. So
Yeah, it requires ventilation drainage. It was blocked. The previous surgeon didn't bother to touch the frontal. You see. And now once the steroid goes, this mucosa is bound to come back to normal. And see the kind of access we have given for the steroid. So judge yourself, first of all, that whether you have given adequate access or not. No else is a better judge than you. Got my point? A half-hearted, limited opening in the frontal is something inviting more problems. See this? What an amazing frontal. I hope you are convinced.
yes, sir. Yes, sir.
Changing to 0 degree. See, follow the beak, you are in frontal. Forget about all that, this cell, this much. There are thousands of people there to confuse you. This is the God's given most stable landmark. See now, my criteria of adequate frontal sinus opening for assessment of whether the irrigation will reach adequately or not. See, my criteria is visualization of the frontal sinus with a 0 degree. 0 degree visualization. See this, Rukna. If you are able to see the interior of the frontal sinus with 0 degree, can you see?
Yes, excellent.
That is my criteria of adequate, frontal sinus opening. Assess yourself. Had I not removed this beak, it would not have been possible.
Yes.
So judge yourself. See this, I can feel now this is adequate frontal sinus opening to push the topicals inside. Agreed? That's it. Now a little bit of this is job. अगला पैराथेराइड एडिनोमा अंडर है क्या? बोला ना उसने, पूछ करना है ना. जो भी है, my job is going to be finished in next 5-10 minutes. So next 10 minutes he will do. I will not demonstrate.
Will you like to debride that mucosa in the frontal because that suits?
No, that is so healthy. So healthy, lovely mucosa. हाँ 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 बोलना. Now next is the sphenoid and the post-ethmoid. See, having this done, we didn't even bother about mentioning the anterethmoidal artery. We did the entire frontal sinus job, and the anterethmoidal was of no mention. Why? Because we are working anteriorly and the anterethmoidal runs on the posterior most part. Yeah, sir.
Somebody asked, what about the sphenoid? Once you are open, should we open the sphenoid as well?
No, I will open the sphenoid. I have not opened yet.
Yes, you will.
Yeah. So now, when to open the sphenoid?
Drugs should reach to all the sinuses.
Yes. Your disease is medical. Don't forget this. Don't try to cure this medical disease with the surgery. See now.
So the purpose of full house weights is to make the drug accessible to all the sinuses.
My day is done, sir, with these words. That is what the message I wanted to convey.
Yeah.
Now, reaching the post-ethmoid, I can go behind the anterethmoids and reach the post-ethmoids. But my concern is how deep I should go, whether I may hit the carotid artery, optic nerve. So many concerns while doing post-ethmoidectomy, because I need to stop while reaching the sphenoid. So how to assess that? So what I will do, I will, अरे बंद कर देना phone यार. I will first open the sphenoid and reorient myself. See now how to open the sphenoid? Simplest way. See my maxillary sinus roof level?
Yes, sir.
Go along the septum. See, this is nasal septum.
Yes, sir.
Absolutely flushing the septum. Absolutely flushing the septum just below the level of the roof of maxilla. See this?
Yes.
I am in the sphenoid. If I don't take this into consideration and try to go higher up there, I will breach the skull base and get a CSF lead. Because what? Whatever. You can name after your name as well. Anybody, people have given different names. I don't want to fall into it. But yes, you can simply remember it as a maxillary line because this is roof of maxilla. Whatever you remember. See now, reason is you don't have to go up because this maxillary sphenoid sinus ostium is more close to the roof than the floor. So make sure that you don't go for it higher up. Otherwise you may breach the skull base. Okay? See, more and more I am dealing with a turbinate. I have used this as a landmark. Still I am keeping it as a landmark. But make sure that this doesn't remain floppy. See now, the entire skull base, anterethmoidal skull base, the maxillary sinus, and now I can finish off the remaining post-ethmoidectomy. See this?
Yes.
Sir, how to find out the enterethmoidal post?
Depending upon the CT scan, how prominent it is. It is not mandatory to go for it. But yes, to prevent complication, best way is positive identification. So if it is more prominent, more pneumatized sinuses, more thin walls, more prominent artery, you have to be more careful. That's it. See now, I am widening the sphenoid. Thick because of osteitis. See the sphenoid sinus.
Yes.
Now this anterior wall, I will carry some there. I'll widen and flush it so that, see my full house FESS now.
Yes, sir.
You don't need any radiology afterwards in future. In your office you put 0 degree and you see everything what you have done. train your patient in proper position, that you have to make sure that the steroid reaches everywhere. Now, the role of surgery is, if anything coming in the way, which is obstructing the steroid reaching anywhere, you have to deal with surgically properly. Inadequate surgical work will not allow it to reach. The biggest cause of failure. If terminate coming in the way, deal with it. If septal deviation coming in the way, treat it. So all are part and parcel of a good sinus surgery. I hope the picture is good there.
Yes, sir.
Now give me 40. So I am widening finally the sphenoid. Be careful while widening the inferior wall. You may damage the septal branch, which may bleed later on. See now, this kind of access, this cannot change. Once this is done, you can tell your patient after the entire bone work is done that in future you don't need a formal sinus surgery, provided you keep irrigating well. Even if you stop irrigation sometime, polyps come back, you can debride in your office because no formal bone work is required. You have already reached to the limits. Start oral steroid in that situation for a short course. Start topical irrigation again, and see now, in the sphenoid with this inferiorly directed undervision, see this mucosal hypertrophy. Don't use blindly any sharp instrument in the sphenoid. See this?
Yes, sir.
That is sphenoid. Give me Carison. See, adequate enterostomies to deliver adequate topicals.
And the care taken while widening the inferiorly, you can elevate the mucosa and then widen.
Yeah. In case you have to widen it more, preserve the vessel. Yeah. See, this is called adequate widening of the sphenoid.
So that the whole side things get
So the same thing what you said, to give access to the topicals adequately. Marocell. See the wide sphenoid, wide maxillary, wide frontal, complete ethmoidectomy flush to the orbit and medial wall here, and you put your 0 degree and this is full house FESS. Full panoramic view of paranasal sinuses. Once done adequately, never required a revision, because now there is no scope of further bone work. You have reached to the limits. That's why I said you can indirectly guarantee your patient after doing this that probably you will not need any formal surgery in future, provided you keep irrigating. That's it. The ball is in your court now. You can tell your patient.
Dr. Satish, at this level, where will be the ethmoid arteries anterior?
Ethmoidal artery is here. This prominence. I am not disturbed because it is not prominent. Here it is. Here it is. And see, while working at the beak, we were working in this direction. And ethmoid artery is a posterior wall in this direction. From beak to this is more than 2 centimeters. Always more than 2 centimeters. So while working in for the frontal sinus towards the beak, you are already centimeters away. So don't get frightened all the time with the vessel. We didn't bother to even mention about it. See now, this is my... What is it?
I brought it because there is a mixed crowd, there are young PGs, so I think there are to be known the landmarks where it is.
So now I can irrigate for a while. This irrigation is key for the remaining whatever mucosal ooze. It can wash away all inflammatory material from the sinuses. De bhai, dhulai de aur.
Yes, sir.
Just keep washing for 5 minutes. Yes, sir.
Hello. Sir, what you would be asking the patient to train the post of irrigation, what you would be asking? Budesonide capsules?
Budesonide rest fuel in normal saline or ringer lactate. Or ringer lactate. Ringer is a better solution now. More physiological. It contains additionally. Yes. See now? That's the kind of work is required. Now imagine somebody asked me what is the need to operate in this case. Could you justify adequate surgery by the previous surgeon? So if that is not justified, so first do your homework first and then train your patient for the topical. If you don't give a good access, don't expect a good result. Yes, please.
Do we need to lower this anterior wall of sphenoid more?
No, not really. Not really. Why? There is no massive disease inside. In case of massive disease inside, you may have to just elevate the periosteum and drill it away or punch it away. See this? The sphenoid is quite good. No need to do anything unnecessarily. Anything else you want me to show on this side? See, we have not infiltrated at all, just using only topical application. And this is the picture at the end. Just train your patient how to make sure the steroid reaches. That's it. That's the only thing left now for his treatment. Thank you so much for your attention.
Thank you, sir. Thank you.
Thank you, sir. It's an excellent demonstration of FESS. Really informative all. Now we are doing small innovation ceremony of 15 minutes. And please you join us virtually from there only. Okay, sir?
Okay, so without confusion, are we showing the parathyroid adenoma?
Yes, sir.
Okay.
After 15 minutes.
Okay.
Yes, sir.
Done.
We are doing small ceremony of 15 minutes.
Okay, enjoy.
You will also join virtually, sir.
Dr. Satish Jain.
Yes, sir.
I am watching you since last around 15 years or so, and every time watching you doing surgery, I have seen in your theater or in any of the workshop, it's always a pleasure.
Thank you, sir. So kind of you. The kind of.
Always one or two small points by repeatedly seeing.
Sir. Thank you, sir. And now Naidu is doing. Yes, yes, please.
By that time, like we are preparing for inauguration, can you please tell us the dose of reduced rescue means how much of ringer lactate, 1 ampule?
Yeah, see, the dose is dictated by the eosinophilia. That's why I told you, before taking the case up, do some groundwork of